Hello, everyone, and welcome to our CPE speaker series. Before we get started, I would like to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit, and today this meeting place is still the home to many Indigenous people from across Turtle Island. We are grateful to have the opportunity to work on this land. My name is Zubin Austin, and I'm the Academic Director for the Center for Practice Excellence, and it's my pleasure to welcome you to today's session focused on pharmacare. Please keep yourself muted during our event today. We'd encourage you to put your questions and comments in the chat, and towards the end of today's presentation, we will be able to access them and present them to our speakers. For now, please let me introduce my co-host for this session, the administrator for the Center for Practice Excellence, Annalise Mathers. Over to you, Annalise.
Thanks so much, Zubin, and welcome everyone. This is our first event of 2023 for our speaker series, so we're really looking forward to getting our discussion underway with Jeff, Joseph, and Mike. Really looking forward to an interactive panel, and then, as Zubin mentioned, opening it up for audience Q&A towards the end of the session. So just before we get started, I just want to introduce our panelists for today very briefly before we jump into our first question set. Jeff Yurek is a pharmacist, co-owner of Yurek Pharmacy, and former Member of Provincial Parliament. After graduating from the Faculty of Pharmacy at the University of Toronto in 1995, Jeff joined the family pharmacy business. In 2011, Jeff pursued a nomination for the Ontario Progressive Conservative Party for the riding of Elgin-Middlesex-London and served for a decade with roles including the official health critic of Her Majesty's loyal opposition. In 2018, Jeff served as Minister of Natural Resources and Forestry, Minister of Transportation, and Minister of the Environment, Conservation and Parks. Thanks for joining us, Jeff. Joseph Berger leads McKesson Canada through leadership and research work and as the Senior Director of Government Affairs. Since 2017, Joseph has helped McKesson navigate the opportunities and challenges related to healthcare public policy in Canada. Joseph has a master's degree in public policy and public administration and has written extensively on social policy issues related to higher education, healthcare, and federal provincial policymaking in Canada. He's deeply interested in exploring how the entire healthcare sector, including both private and public entities, can work collaboratively to improve health outcomes, equity, and access to care. Thanks for joining us today, Joseph. And last but certainly not least is Mike Sullivan. Mike co-founded Cubic Health in 2003 and serves as the company's Chief Executive Officer. Cubic provides plan analytics and clinically based solutions to self-insured health benefit plans. Mike began his career as a community pharmacist and has previous experience working in both the pharmaceutical and benefits consulting industries. He's a frequent speaker, both domestically and internationally, on topics related to health benefit plans for groups such as the International Foundation of Employee Benefit Plans, International Society of Certified Employee Benefit Specialists, Canadian Pension and Benefits Institute, and the Conference Board of Canada. We're very lucky to have you with us today, Mike, as well as our other panelists. And let's jump into it. Zubin, I'll pass the mic over to you to get us started.
Thank you, Annalise. Let me get started with our first question for our panel today. So as you all know, drugs are the second biggest expenditure in healthcare after hospitals, yet we know there are huge gaps in coverage with approximately 20% of Canadians struggling to pay for their medications. Unusually, Canada is the only country in the world with universal healthcare that does not provide universal coverage for prescription drugs. And instead, we rely on a patchwork of more than 100 government-run drug insurance programs, more than 100,000 private drug insurance plans, and this can create large gaps and disparities regarding availability and affordability of prescription drugs. So my question for our panel today relates to the word we're using. The term pharmacare gets used a lot, but seems to have different meanings to different people. So I'm going to ask each of our panelists what they think the general understanding of the term is, but from their particular perspective, do you think the general understanding is helpful, or should we be looking at something a little bit more specific, another more particular definition of pharmacare? Joseph, I'll ask you first. You're the reason we're having this session. You did a speaker series event for us last year, which was one of our most popular events ever. So you started this whole problem. Tell us what you think about the term pharmacare.
Thanks, Zubin and Annalise, and thanks for having me back. I'm always excited to have conversations about this topic. And I didn't start the problem. The problem started, I mean, we can trace the roots of this public policy problem for decades. But let's say that the current iteration of the pharmacare policy problem really goes back a few years to the Trudeau government's decision to put together an advisory panel on implementing what they called national pharmacare, and former Minister Hoskins in Ontario was leading that initiative. What has been really challenging to really having a fulsome and productive policy discussion in this country is that no one at a high level has sort of described or defined what pharmacare means to them. I don't know that anyone on the call, panelists or participants, could tell you what Justin Trudeau thinks national pharmacare really means. And after 5 years of sort of waiting for this policy to evolve, it seems to be deliberate. I think the knee-jerk kind of standard definition of pharmacare that you asked about, for most Canadians who are not kind of policy wonks, would simply mean when you go to a pharmacy, you show them your provincial healthcare card, your medication is covered either entirely or almost entirely, maybe you chip in a few bucks and you walk away.
So is that so bad? Is that so wrong, that kind of understanding of pharmacare?
Not at all. And I think it makes a lot of sense, right? That's how, our publicly funded and delivered healthcare services tend to work in this country. The challenge, I think, is that it assumes that we're starting from nothing. And I think what we've seen, particularly those of us who've investigated this issue for the last few years or even decades, is that we have a system that is functioning pretty well despite itself. So despite the fact that we have hundreds of programs, that's right, it's a patchwork and it doesn't make sense in theory, but in practice, most Canadians are pretty pleased with the level and the comprehensiveness and the affordability of their coverage, whether they've got, an employer-sponsored plan or a public plan. The immediate problem to solve is that sliver of the population, whether it's 5, 10, 20%, that doesn't have access to affordable, comprehensive drug coverage. And I think, without having a broad definition of what we intend to achieve from a policy goal perspective, it's hard to design programs and debate them. So until the federal government is willing, when we say pharmacare, we mean that every Canadian has coverage regardless of who pays for it. That would mean one thing. If they say, well, what we mean is a single payer system whereby we nationalize the private insurance sector and get rid of the provincial drug plans, that's a whole other kettle of fish. And in the absence of that kind of clarity, we tend to spin in circles and have conversations that are rooted in cliches more than anything.
Perfect. Thank you, Joseph. Mike, let me turn it over to you. Joseph has declared that our system works pretty well already. You may have some opinions on that, but in particular, how do you think that the general understanding of what pharmacare is might interfere with or perhaps help the debate to advance?
I actually agree a lot of what Joseph said. I will say, Zubin, I think the definition of pharmacare is the biggest problem, and I think it's what stumbles us and gets and really is preventing all of us from making more progress on it at different levels. I think in certain areas, pharmacare is seen as government first payer. You don't have to bring your credit card, like you wouldn't have to bring it to a hospital. Whatever you feel you need or you do need is covered, and away we go. And that it has to be government first payer, and that's the way around it. And that's fine. That's one model. I just don't think that that's a model that's even remotely feasible to consider in the years ahead, given where we're at with healthcare funding at the provincial level, the issues that we have that are well documented about how we even catch up with where we've been in the last few years. And so I think that's really a problematic definition, is to think of it in those terms. And I also think because we're not clear about the definition, I don't think it gives a lot of clarity about where the starting line should be. And so that's fundamentally, I think, until we can kind of get there and maybe have slightly different goals, this is going to become a very frustrating topic, or continue to be a very frustrating topic.
So a pretty provocative statement from Mike, the idea that it just doesn't seem feasible. The general understanding of pharmacare, and particularly perhaps what sort of the average patient or citizen thinks of pharmacare, it just doesn't seem likely given all of the cluster of factors that we're going to be discussing later today. Jeff, let me turn it over to you. So you are a pharmacist. You have recently been a politician, a minister, and you've sort of seen this issue from a lot of different perspectives. What do you think about some of the definitional problems around what the public might expect pharmacare to be, and how it sort of factors into why we seem to constantly be stuck running around in circles on this issue?
Yeah, no, thanks. And I agree with Joseph and Mike in that there is the definition, the expectation that the average citizen would have probably doesn't define into a solution for the pharmacare issue. You know, pharmacare in general is such a nice issue for politicians to roll out during elections, or having conversations to create a committee to look and review and come back with a report. And that seems to feel like they're accomplishing something, and people who are out there voting thinking, well, they're looking after me, this pharmacare issue. But I think until they do come out with a definition of what the end goal is going to be, we'll never get pharmacare off the boards, off the table to be in policy. I'd love for politicians, governments to reach out and do some roundtables with average citizens around the country to see what they would expect from pharmacare. They might be shocked at what people would actually accept. I mean, if you have a drug plan, private plan that's paying well, usually those plans do much better in coverage than government-run programs, and those folks would probably say, I'm fine, I don't need one. Whereas you have folks that are making a minimum wage without any benefits going, I think some form of coverage for me would be great. So I think until somebody reaches out and comes with a workable definition, I don't think we're going to get on the path to having a pharmacare program for the country. We've heard it from the experts, we've heard it from the ideologues, and we've heard it from politicians, but there's been no solutions put forward, or I don't think any much of a traction that is gaining any ground. So until we get to that definition, until we get an agreement across the country what it would look at like, I think we're kind of spinning our tires.
Thank you to all of you. Let me turn it over to Annalise for the next question.
Yeah, thanks, Zubin, and thanks to all of you for just getting that discussion going. Joseph, you kind of, mentioned this, the pharmacare conversation has literally been going on for decades, I think since the 1960s even. And as, each of you have sort of touched on in some of your comments so far today, the pharmacare discussion seems to bring up a lot of contentious issues around political agendas that might differ, equity concerns, efficiency arguments, and even some ideological differences. So I think, it's 2023 now. Why are we still talking about this issue, and why does it seem so stubborn to solve? And I think I'd be curious to hear how each of you might think we can actually begin to parse out some of these questions or these differences to move forward with trying to solve this problem. Mike, maybe I'll turn to you first to comment on this.
I think the first thing that has to sort of be acknowledged is the structural issue that exists today with private plans and public plans paying very different amounts for the same drug. So because all of the provincial plans participate in PCPA and have access to discounts and risk-sharing agreements that aren't accessible to the rest of the market, you've already got a two-tiered system here where the ground is not level. And so I think initially, right then and there, we have to start saying, well, hold on a second. Does that not seem like maybe the most intelligent place to start is, what if we're all working from the same base, and what would that mean? But I think the concern there is, to the extent that the public programs allowed private players into that space, it would lessen the slice of the pie that they get, because they've done a better job of negotiating agreements. So they get far more consideration than the private sector gets. And so if that's not possible, then there's the first big barrier we have to deal with. And just for the sake of the audience, let's use round numbers. I'm going to guess that in 2022, private plans, employer-sponsored plans, multi-employer plans, et cetera, I'm going to assume that they paid somewhere in the order of magnitude of about 18 to 20 billion dollars for prescription drugs for Canadians. And so how do you take that money out of circulation and put it in, I think, is one thing. And so I think if we just make the basic assumption that where are we going to find that kind of money in the system today, given every other priority, it's not likely possible, then how do we start to try to enhance what's happening on both sides so they become more complementary? And so there's a perfect place for us to start. And there's an example, Annalise, I think of a more tangible front end goal to say, as opposed to sitting down and trying to eat this orca, can we maybe look at something a little bit more meaningful as an initial goal and work our way from there?
Yeah, thanks so much, Mike. Jeff, would you like to build on some of that?
Sure. I would take it from the political side of the argument. Pharmacare isn't a standalone issue. You bring Pharmacare in, you're now going to have a battle between two different levels of government of who oversees it, who makes the decisions. And I know coming from a provincial government, provincial governments don't like being told what to do from the federal government, in particular as a piece of policy they see as their own. Pharmacare is going to affect the overall budgets. As Mike was saying, the amount of money that would have to be infused into the system, that money is either coming from the taxpayers or coming from other programs in the government system. So you might see other ministries being shaved off. Economic development. I know coverage of some drugs does play off in Ontario and Quebec with regards to attracting brand name manufacturers and generic manufacturers. Mention the money, the taxes, and the debt that the government will have to manage, both sides, and still be able to get reelected at the end of the day. And then taking it down more on a local level, I think the scopes of practice of the different healthcare professionals out there aren't the same across the country and going to have to be modernized and brought into line with one another to develop that equity. And then you'll be getting the fights between various healthcare professionals on their turf that they like to maintain and not give up. So I honestly think the federal government has tried a little bit a test run with the dental program they brought out. The provincial government brought theirs out a few years back, and they were focused more on filling in the gaps and only hitting subsections of the population. And maybe that's a template that the federal government should look at with the Pharmacare program and see how they're going to fund the government and work with each of the individual provinces and territories to deliver that program.
Yeah, thanks so much, Jeff. I think you highlight a number of really good points there, and just, really taking stock of, I think, the number of gaps that are across our healthcare system, provincially, territorial, but also in scope of practice. And for lots of people on this call, that's probably particularly relevant given the recent change in scope of practice for pharmacists in Ontario. So thank you for those remarks. Joseph, I'll turn to you next for some comments on that topic.
Sure. I know you want fireworks in a panel discussion and hopefully some conflict, but I'm going to have to just endorse everything that Mike and Jeff said. I mean, I think they've both of them have laid out the sort of structural, institutional, or just sort of inertia, whatever the adjective of inertia is, related reasons why, like a chief of a massively new, different, shiny national pharmacare program it's just there are too many what I imagine to be sort of insurmountable objectives, the Constitution being the first one of them, right? You're never going to have a national one-size-fits-all program because that's just not how social policy works in Canada. And so I think that the challenge, to get back to your question of like why haven't we achieved success on this file, is because it gets back to the initial discussion around what do we intend to achieve with Pharmacare. What's the objective here? If the objective is to build something new and exciting and shiny and expensive, there's just no pathway for that. If the objective is to continuously, incrementally improve our system on all fronts, whether it's scope of practice or pricing or coverage criteria, there's a lot of not necessarily low-hanging a lot of good that can be achieved for relatively affordable amounts of money, right? So it might cost $20 billion to move everyone on a private plan into the public system, which wouldn't close the gap in coverage. You've got to find additional billions for the folks who don't have any plans. But for a handful of $1 billion, you could close the gap in every province by expanding, the provincial drug plan to anyone who doesn't have access to another form of coverage, which is essentially the model that we sort of developed when we began this policy work a few years ago. So maybe the focus needs to be in the next round of policy discussions on this file on achieving some of the relatively small but still really meaningful objectives to create the most efficient patchwork of programs that we can get, recognizing that the one-size-fits-all national program is just going to occupy too much energy and money and time that we just don't have, and is going to require too much, sort of seeding of policy control, and too much, and is going to require trust, right? That's the other piece that's missing in all this. If the federal government wants to take a leadership role on this file, it needs the provincial premiers to acknowledge that the feds are going to see it through in the medium and long term. And it's easy to say, well, look, we've got a few $1 billion to spend, and we've got a 5-year, framework or what have you. But to entrust all the policy decisions around who gets coverage, what gets covered, how much of it is covered, how are the prices going to be negotiated, to cede all that from a provincial perspective to the federal government, it's just, it seems unlikely at the best of times, and super unlikely when you've got different parties in control in provincial capitals than you do in Ottawa.
Yeah, thanks, Joseph. I hear a little bit of an unprecedented level of collaboration that would be required on.
And like full disclosure, I'm a Montrealer. I'm in Quebec, so that's the first which we view all of these discussions as like, okay, we're going to have a national program. How exactly is Quebec going to opt out? Well, if Quebec is going to opt out, then Alberta is going to opt out, and Ontario, like the dominoes will fall, and then we lose track of a conversation that's supposed to be about improving access to medication, and becomes really about like political turf, battles.
And it enriches our conversation so much to have you here, Joseph, and advocating for Quebec in this debate. Thank you so much, Zubin. I'm going to flip it back to you to continue our conversation.
I'm going to be going a little bit off-piste here, but all of your comments actually made me wonder, is this a partisan political issue, or is it a constitutional structural issue? Is it fair to say that conservative and progressive conservative politicians or reform politicians are against big public programs like this, while more traditionally left-leaning parties like the NDP are for it and the Liberals are somewhere in between? Is this really a partisan issue, or is there more on the political level than most Canadians might see? Any of you who'd like to answer that, be interested in what you have to say.
Jeff, I'll let you go first. I have some things to say, but it would be ridiculous for any of us to speak before you do on this one.
I was playing the politician. I was waiting to see what you guys said. And then follow up. No, you know what? I honestly, I don't think there is excluding the Reform Canadian Alliance PPC type voter who obviously has their thoughts on how small government should be. I honestly believe it's more of an issue between how we're going to get there, and how is it going to be affordable, and how is it going to not decimate our economy and our other resources that we have to make government work. And I think on the spectrum, you see where the Conservatives are more focused on the costs and how it's going to be delivered, where if you go to the other side of the NDP let's put the program in place. There's lots of tax dollars out there to figure out how to fund this model, and you get everywhere in between. So I think with the governments of today, Conservatives are in power in many of the provinces today, and they have their drug programs up and running. They haven't slashed them to the ground or removed them. They've worked at ways to make them more efficient. You could argue whether or not that has worked or not, but I think it's more of how policy is developed and what's your focus on implementing a policy.
I'm old enough to remember an expression from the 1970s, and that was only Nixon can go to China. Are we more likely to see advancement in this file if we actually had a conservative federal government? We didn't in previous conservative federal governments, but is the idea that somehow like people expect a certain kind of behavior, partisan behavior from Liberal or NDP led governments, but you know, is it only a conservative government that's actually going to lead us forward in this?
I'm not sure.
Go ahead.
Go ahead.
No,
Oh,
I
yeah.
was going to say no, but go ahead, Joseph.
Yeah, I'm not sure that, like, I think broadly speaking, ideologically, if you know, the sort of like the left, the NDP kind of ideologically is pretty clear that they would like to see, you know, universal single payer pharmacare, dental care, mental health care, vision care, like basically any health service should be fully and completely funded and paid for by government, right? And I think on the other end, on the conservative side, it's the small government impulse that probably rules the day there. And as Mike pointed out, if the federal government is going to take on this role, they've got to find like tens of billions of dollars in annual expenditure, and it's hard to imagine a conservative government coming to power being willing to spend that kind of money on new programs. And so then you're left with kind of the liberals who are sort of in the middle, and even within the liberal caucus, like from day one. So if you remember when the prime minister announced the Hoskins panel in the budget, I think it was 2018, you know, the budget happens and then they send all the cabinet ministers to give talks at like the Canadian Club and that sort of thing. And Bill Morneau, I think gave a series of speeches in like Montreal, Toronto, and Vancouver, and basically said, don't worry, we're not doing the single payer change here. We're going to do a fill the gaps model, right? And so, and kind of short circuited some of the policy generation internally in Ottawa. It's interesting to note that Bill Morneau is now a former politician and not a current politician. But that's been the dynamic in the Liberal Party, right, all along. You've got some members who want to go to the single payer kind of NDP vision, others who are much more restrictive and would like a more moderate or conservative version of pharmacare implemented. I think what's really interesting is there are kind of arguments on all sides for implementing different versions of pharmacare. Like there's a conservative argument for single payer pharmacare, which is that, well, if you have single payer, you can use economies of scale to drive the price down, right? And so it may cost government more, but it'll save the system money. That being said, I don't know that there is a conservative government, to Jeff's point, that had, or a conservative politician that would have a roadmap to implementation that, you know, get you there. I think that's where the rubber kind of hits the road. And so you wind up in this weird situation where there's broad agreement that everybody should have access to drug coverage, and the kind of ideological differences are more about how you get there and who you're comfortable with footing the bill. And I think on either extreme end, on the conservative side, you want government spending as little as possible, and on the liberal side, you want government spending as much as possible. And then there's the 65% of the middle of the country that just wants to see some progress, regardless of what the underlying conditions are. And I think that's why we haven't had any movement on this file, because it's not a political winner. It's not winning votes in any riding in the country.
So Mike, you had some thoughts on this issue, and having heard Jeff and Joseph, what are your thoughts on sort of the partisan issues involved in this?
Just as a quick disclaimer, I'm apolitical, so I want that to be on the record. I have a low opinion of every political party. And the other disclaimer I would give is, if we all lived in the Garden of Eden and money was just flowing off trees where we could pay for daycare and that would have been nice for me, you know, 8 years ago or 10 years ago. If we could pay for, you know, post-secondary education for everybody, healthcare for everyone, drugs, dental, everything, sign me up for that utopia tomorrow. So I just want to say that, you know, in a world where we don't have to worry about constraints, that sounds really good. And I don't think anybody could argue that a single payer system that's well designed, that's well governed, that can operate at scale, I don't think anybody would argue that that's not a great idea in theory. But you know, let's get realistic for a second. So just a couple of points of that, Zubin. we ran analytics on the NDP essential medicines list on a number of benefit plans, and you would be shocked at how little of that essential medicines list is what's actually being claimed by Canadians today. It was less than 30% in most cases. So now my big concern is when you have politicians and political platforms that are profoundly poorly informed and haven't done any real thinking or any real measurement about what's reality and what this is going to mean, we're going to end up with two really substantial unintended consequences that I can see at the top. The first one is most of the public sector benefit plans, public sector employers are not under the same jurisdiction as the provincial programs in that province. So for example, if you're a University of Toronto employee, you're not somehow benefiting from the rates that ODB is paying for drugs behind the scenes. You're paying the full freight through your benefit advice, through your benefit plan, your insurance company. So most public sector employers have unions that have collectively bargained benefits. They are never going to give up that 70% of the claiming that is going to disappear if we ended up on that sort of NDP type of model. And they're going to say, this has been collectively bargained. It's a labor issue. It's not going to work. So what's going to happen is we're going to have a bunch of private sector employers fold up shop, go to some sort of quote unquote lesser, or perceived to be lesser formulary. And the public employees will end up with something very different, and they'll be grandparented in with coverage. And so how are we going to deal with that? Because I think we're only further exacerbating a massive issue in this country that's not spoken about enough. And that is, we're creating a class system in Canada between the public sector and the private sector, because all of the job loss in the pandemic came out of the private sector. The public sector grew. And so, when you're a private sector employer, you're paying a healthcare tax in Ontario on your payroll every day, with every payroll. What is that going to look like when all of a sudden you take that away and you have to start funding this? And the second point I was going to make is, so you're going to have these disparities because of the influence of large labor on the public side. The second point I was going to make is, we have to think about the unintended consequences to the financial structure. So the second part on the private payer side is, the nice thing about health benefits, and let's put drugs aside for a second, just general health benefits, it's tax-free compensation to the employee or to the family member. So if you're receiving paramedical services, drug services, whatever it happens to be, it's all tax-free. So there's a win to the employer, it's tax deductible, and there's a win to the member, it's tax-free compensation. If all of a sudden we fold up these plans, one of the unintended consequences is going to be that there's a very good likelihood that many of these small to medium-sized employers on the private side will fold up their health benefit plans too and move to a healthcare spending account and put a limit on, okay, here's a bit of money in a healthcare spending account for dental, paramedical, you name it, and go from there. Now, how does the average person make an informed healthcare decision? So if you've got $3,000 in a healthcare spending account and you've got a 14-year-old that needs braces and that money all goes there, then how are we making healthcare decisions as a family unit when we don't have a plan to lead us and to be able to provide that? So we have to think about the bigger picture here, and it starts, Zubin, with the question that you talked about on the political side. And we have to think about some of those unintended consequences, which could be really, really significant, which is why I really believe we have to start looking at this in a more practical manner to make some headway thoughtfully.
Thank you. Very provocative thoughts and comments there. And it does lead into, I guess, the next question. And that's really about where pharmacare falls into not just current healthcare priorities, but current public policy priorities. As we are gradually making our way out of the pandemic, we know our health system seems to be on the verge of collapse, particularly primary care systems. We have a burned out workforce. We have unprecedented demands. We also have a whole host of other pressing public priority issues that governments of all kinds and at all levels are struggling to deal with. I, for one, have been waiting for 3 months for a passport, and I haven't been able to get it. But There's so many things right now that seem to be going wrong and that are priorities. Where does pharmacare fall into this? And for those who are really advocates and passionate for pharmacare, how do we actually make it register as a public policy priority at this point? Jeff, let me start with you on that.
Well, I think you hit the nail on the head post-pandemic on what's happening in our healthcare system. Not only ERs are overflowing, wait lists are expanding. The staffing, the human resources component across the country is stretched beyond belief. I don't think the average person is thinking we should be focusing on pharmacare, and I don't think governments have that at the top of the list as well, because it's going to be a big spend, and as Joseph mentioned, it's not a political winner no matter what you do with that issue. So I think that it's something that I think we got to look at piecemeal in order to bring that forward as an issue. How can pharmacare complement the issues going on in the healthcare system to reduce the burden that's ongoing? How does the expansion of drug coverage work to lower the ER wait times? I mean, the scope of practice change in Ontario with minor ailments is going to help alleviate the ER crisis, et cetera, and we can now write for prescriptions that are mostly covered on most drug plans available to people right now. How can we expand upon the expansion of the pharmacare system that is going to help with the human resources issues, et cetera? And I think that's a way to push the issue back to the forefront with the governments. Mike had a great speech in his last answer. I think he hit nail on the head, and some of that I would have spoken verbatim back in my political days as some of the comments that he made. But I think in general, there has to be an avenue to show the folks that moving into a pharmacare system is going to benefit the healthcare system. It's going to benefit their individual lives, because that's end of the day what they're concerned about is when I need to get my daughter a prescription for amoxicillin that I'm not going to be paying. Amoxicillin, I'm being facetious with the pricing, but I'm not going to be going into debt trying to make that happen because some government made a clumsy move and destroyed my private coverage.
Okay. Joseph, any thoughts in terms of how to make this a public policy priority, given all the other simultaneous issues facing individuals in society and governments?
Sure. So before I answer that, Jeff served up a meatball pitch that I just have to swing at, which is amoxicillin. Which, if you wanted to get amoxicillin for your daughter, you'd struggle because it's been in shortage for the last 2 months. And why do we have more and more drug shortages that last longer and longer? Because pharma policy in this country for the last 15, 20, whatever years has been achieve cost savings no matter what. Right. And if that means that we have a weaker drug supply chain, that we are not fully using pharmacist scope of practice, that we have less, domestic manufacturing of medications, so be it. And now we're kind of reaping what we sow a little bit. That being said, I'm glad you asked about the sort of where pharmacare ranks in prioritization. And I anticipated that question, and I have some data. And I'll shout out, I think Shelley Ditani from Neighborhood Pharmacy is on the call, and Neighborhood commissioned some polling a couple of years back. And I think if you Google it, you'll find it. One of the questions they asked right off the top was, are you in favor of national pharmacare? And everybody who answered the poll said, yes, of course. It's like asking people if they like, donuts or French fries. A subsequent question said, okay, here's a dozen healthcare priorities. Where would you direct new money? And pharmacare went from something everybody wanted to the bottom of the list. And why was it at the bottom of the list? Because we can't eat donuts and French fries when we haven't had our meal, when we haven't had protein and complex carbohydrates. The items that ranked higher on the list, no surprise, aging population, wait times, mental health, access to physicians, emergency care, cancer, human resources, in particular nurses, pharmacists, etc. Generally speaking, we're all in favor of more of every kind of healthcare, but when we actually have to sit down and make priorities, which is really what government is all about, public policy is really a question of how you allocate scarce resources to solve collective problems. When it comes down to it, the problems of access to medication, while significant, particularly for those who don't have coverage or whose coverage is not adequate to cover their needs, right? And this is something that we typically see on the public side, right? If you've got a private plan with, patient contributions and a comprehensive formulary, you may have an easier time affording your medication than if you're relying on a public plan that is more scarce in terms of what it covers. But when it comes down to it, generally speaking, the really urgent and critical problems in our healthcare system are not about access to medication. They're about basic access to care. So you can have the best drug plan in the world, but if you can't see a physician to issue a prescription for you, or it's not one of the minor ailments that a pharmacist can prescribe, that drug plan is just going to sit on the shelf and do nothing for you because you won't have actually any access to care. And so how you make it a priority, I think, is by solving the other problems in Canadian healthcare, which is like kind of punting your question, because there are no quick, immediate solutions to any of the challenges related to healthcare. But it's interesting to see in the negotiations between Ottawa and the provinces on the health transfer, which is supposed to come to a head any day now, even for a government that has explicitly endorsed pharmacare, it's not one of their priorities, right? Their priorities are on LTC, they're on aging population, they're on healthcare human resources, they're on data collection and innovation, but they're not on expanding access to medication, which is frustrating for those of us who see the incredible opportunities to create some slack and capacity in the system by having a stronger drug coverage system. But at the end of the day, the real pressing challenges are elsewhere in healthcare, and that's when this initiative began a few years ago, we were dealing with a government that could spend as much as it wanted, that could rely on economic growth, where money was cheap. All that has changed considerably in the last few years, and so we've got to be aware of the context we're operating.
Thank you. And we've got some interesting comments in the chat, which we'll get to in a few moments, where there may be some people that have some disagreements with what you've just said. We'll get to that in a moment, but before going to the audience, I'd just like to ask Mike to round out his views on what you've heard from your colleagues on the panel. Mike.
I would love to see this rise to the top of the public policy conversation, but more the Canadian conversation, kind of building on what both Jeff and Joseph just said. Exactly to the point that was just made. If we can all get on the same train that, yeah, this is possible, as long as it's entirely evidence-based, is everybody good with that? So first of all, where are we going to put this on the list around, hip replacements, knee replacements, other things like that, everything that's happening in the challenges in the healthcare system today? Great. Okay, so let's just assume that pharmacare and having access to necessary drug coverage is right at the top of that list or very close to it. Okay, great. So to make this sustainable, I'd just like to get a pulse of the Canadian population to say, are you good if we do this, but it's going to be evidence-based? Because it's the only way we can make this happen. And then are you okay with some of the potential fallout from that? So for example, you want to make it evidence-based, stop approving drugs that cost $250,000 a year that don't work, that have no actual clinical benefit. So let's start there. Why don't we stop funding cancer drugs that increase the, where overall survival is enhanced by the matter of a handful of weeks or a couple of months? I'm saying that as someone who has cancer littered all over his family. So I'm not saying that from some rooftop to be unsympathetic. Are we good with that? Can we agree with, let's just, a lot of this cancer therapy is fundamentally useless. And we haven't had a lot of breakthroughs. I mean, some of the therapeutic modalities aside, if we got on board with that? So, we talk about, say, for example, the administrative cost of these kinds of plans. What happens when you start to eliminate funding of meds that really are not adding any value within there? Are we still on board with that? Are we still okay with it? And can we all make the sacrifice to get to that fundamental center point where we can all support, collectively, where 80% of us can get behind it? Or is it going to get tribal? And is it going to get political about specific therapeutic areas? And what do we do there? And then to Joseph's point, and he would know this infinitely more than I would, and as would Jeff, okay, then we want to get tough and get evidence-based because that's the only objective measures that we can put in the playing field that we can all point to. are we going to be comfortable with the fallout with pharmaceutical manufacturers who say, well, you know what, we'll come back to Canada down the road. We're gonna launch around the world and come back later because we're not very happy with being left off your list. And so what does that mean for us at the end of the day? So it's super, super complicated, but are we actually, could we maybe take this away from being a political discussion where people are pointing their finger at Trudeau or pointing their finger at Singh or pointing their finger at anybody else and saying, wait, your policies don't make any sense, to what would we actually accept as Canadians if this is a priority? And I think if we had to take our medicine, pun intended, that would not, people would not be very happy with that. And until we kind of get real with that, I think, I don't know how much progress we make.
Fascinating.
Just add into that, Zubin, just quickly, I think at the same time, Mike, excellent point, is to have the discussion with people on what a deductible and co-payment would look like for that drug plan, and what are the income levels that the government's going to put forward to when you pay more. Is it the Ontario model where it's 20 some odd thousand, you're considered high income? Is it 50? Is it 100? Is it 150? Do you get cut off if you make more than $200,000 a year and you're on your own? I think that discussion has to happen as well, so that people can go, okay, I'm okay with moving forward and going to the single payer model. Because any program that has come out from any government has always had, in the last few years, has been based on your ability to pay. And the more you make, the less benefit you get from the program the government's coming out. So I think that discussion should be tacked on to what Mike has brought forward, which I think is excellent.
Yeah, that's a great point, because I think, if we can get the class of people that pay their $100 deductible to ODB every year, and then jump in their Maserati and drive up to Muskoka and sit in their $5 million cottage for the summer, if, as long as they're also on board with the fact that, oh, like, guess what, it's not a $100 deductible anymore too. Like, we get everybody, we start talking about this fallout, because in Ontario, we haven't gone past a $100 deductible in 611 in what, 30 years? So that's what I mean. Like, I think as Canadians, if we all look in the mirror, we can all agree, yeah, I think we can find what the middle of the normal curve looks like in terms of the medicine that we're willing to swallow. Then we get to move it forward. And I think it becomes more productive, because it's less about if you're red or you're orange or you're blue, and, really and truly what we're going to accept. And it hasn't been too many provincial governments here in Ontario have been successful upping the ante on the copay with seniors in the last 30 years. So yeah, that seems like an interesting place to start.
I have seen the enemy, and he is us, apparently. Some really interesting words of thought there. I'm going to pass it over to Annalise now. We're going to be going into the chat and into some of the questions that we've received prior to today's session. Good luck with those, gentlemen. Over to you, Annalise.
Thanks so much, Zubin, and thanks, everyone. A few comments, questions in the chat. Leslie, I'm going to start with your first question, and if you're comfortable, feel free to just unmute yourself, because your first comment around moving to a one-payer system, freeing up resources, I'd be happy for you to articulate on that.
Yeah, thanks, Annalise. Great talk, everyone. Yeah, I think Mike has tried to address, the inefficiencies, in the system. However, I mean, I've worked in the UK and here, and there are so many inefficiencies in the system, delays in treatment, and the transaction costs, pharmacy benefits managers, multiple, more than one insurance doing prior authorization for a single patient, patient support programs who are starting people on drugs before they have prior authorization, who have no oversight, who don't even complete paperwork for patients on time. So I have worked in both systems. So there must be heavy administration costs associated with the way that we manage drugs. So, I mean, if you had a single payer, I mean, you're talking like we're not paying for these drugs already. We are. I have had patients who have been fired from their jobs because their companies cannot afford to pay for their drugs when they're put on a specialty drug. So we're still paying for them. It's just the way that we're paying for them. Right. And, I've worked in the UK. It's not just about covering the cost. It's about quality too. In the UK, we monitor prescribing trends. We can influence the choices of medications used to promote quality prescribing so that patients on cholesterol drugs, they're put on the cheapest one, their cholesterol is controlled, there are targets, and here there's none of that happens. It's a free-for-all. No one knows what statin is top of, for example, Empire Life versus Sun. Like, they might know. We don't know. We also don't. The opioid crisis was partly due to the fact none of us even saw it coming because no one was monitoring the prescribing until ODPRN started doing it. So this is not just about coverage. It's not just about cost. It's also about having control over what we're prescribing in this country, having decisions made before drugs come on the market to say, are we going to approve this drug? Having consensus with physicians. I have patients, sorry to keep rambling, I have patients who doctors and insurance companies are completely disconnected. The doctors are ahead of the game. Well, you know, they obviously there's inappropriate prescribing for sure, but there's such a lack of the system for me, having worked in the UK in this area and working here, is so inefficient here. And it's not helpful. Patients come bottom of the pile because even for drug shortages, for example, patients have to get prior authorization when there's a shortage for the other drug. And that takes a month. So I have patients, kids right now with Humatrope, haven't got drugs for 6 weeks because they're waiting to get approval from the insurance company for the alternative because they can't get their drugs. So the system, it's not just about the payer, it's about the structure of the system itself. Multiple players with not much oversight, no transparency. That is a huge part of the problem.
Yeah, thanks so much, Leslie. I think you've raised a couple of good points there. Kind of going back to our conversation about the one payer system versus multiple payers, and then also some of the pieces about actual prescribing policies. And maybe that's actually where I'd like to take the conversation with Jeff, Joseph, and Mike is looking at, you know, Leslie has the example of sort of national guideline prescribing like in the UK. Connie also made a comment in the chat about perhaps looking at like the WHO's list of essential drugs. What are your thoughts on where we go with actual prescribing practices as it relates to pharmacare?
Annalise, I just want to respond initially to Leslie's thoughtful questions in chat and her commentary. The one point I just wanted to make, and we could talk about this for hours, is it's everything you just mentioned in your question, Annalise, is what needs to be the priority, and everything that Leslie talked about being frontline and seeing patients needs to be the priority. And one of the things that drives me bananas about the pharmacare debate is when you get, apologies, Zubin, academics that sort of talk about, well, you know, this system, there's just so much administrative cost built into this. Let me give you an example of something I looked at today. It was a collection of public sector employers. The combined prescription drug spend for this just one group, $265 million last year across less than 2.5 million prescriptions. So the average cost per claim is over $100. The actual administrative costs on those claims would be less than 3%, all in, everything in. Now, Leslie's brought up some really thoughtful points about there's you know, the administrative costs into the hard costs, it's the delays, it's all this other stuff. It's very, very good point. But back when the average drug cost was $35 or $40, the administrative bloat was huge. Now it's less of an issue, which is why I wish people would make it less of a problem. The issue is not the fact that there's inefficiencies administratively. That cost is minimal. The real cost is no one is paying attention to what we're actually doing, going back to my previous comments about being evidence-based and being thoughtful and thinking about and going from the patient up. So Leslie's points are very, very well taken, but we need to get rid of this idea that somehow if we just got that administrative cost, then all of a sudden we found the money to pay for this. We haven't. We need to focus on the pieces that Leslie highlighted at the member level. And we need to leverage technology to make that happen faster. And there's no reason why it shouldn't. And a lot of these people are using technology that was built in the 1980s. So we got to fix that. But I just want to make sure moving forward that the points that Leslie was making about the end, what resonates with the end patient, that has to come first in the conversation, not the idea of inefficient administration.
Thanks so much, Mike. Joseph or Jeff, would you like to weigh in on what Mike's just said and or the prescribing practice? Take it in whatever direction.
Yeah, it's a great question and a great set of real life challenges with our system. I think we're sort of stuck we're going to be stuck structurally with many systems, just because of the nature of Canadian public policy and Canadian healthcare. That being said, if you're a federal government and you've got money to spend in this area, if your first order of business is to everything, then you've got no money left over to incentivize technological adoption, innovation, patient-centeredness, reduction of friction in the system. So one of the ways that Ottawa could move forward is to say, we're going to make money available to modernize the pharmacy sector, everything from what occurs in the pharmacy to what happens with insurance companies, to reduce friction, to expand our ability to capture and evaluate data about quality and patient outcomes. That's not an easy task, and it requires buy-in, it requires money. But if your objective is, well, let's just pay for everything and then hope that it works out in the end, I don't know that we've got a good track record of that in this country with government-run programs.
Thanks, Joseph. And Jeff, maybe I'll pass it to you for some last remarks before we wrap up for today.
Yeah, thanks very much. I mean, I think the opportunity for what was asked, I think it lies with healthcare professionals working together and sharing their scopes of practice and turf where it can happen. I think there's a key role for pharmacists to play in following prescribing protocol. They're the ones that lose their money when the insurers come by. The doctors don't get their money scooped for not following prescribing protocol, but it is the pharmacists. So I think we need to get an understanding between our colleges across the country to work together to standardize. I think our associations that represent us to the governments and lobby on our behalf need to work together in unison. I'm still shocked at some of the pushback we received from the OMA when pharmacists got the prescribing rights for minor ailments. I was really floored at the fact that this is going to be a beneficial tool with so many prescribing protocols in place for pharmacists to follow. I think we can achieve, as Mike said, the administrative isn't the issue with the cost. It's the actual usage of the costs of the drugs in our system. And I think it's a huge opportunity pharmacists can step up and actually play a key role in guiding pharmacare into some form or another in throughout Canada. But it has to start with the province's regulatory bodies getting together and starting to level out that field.
That's fantastic. Thank you so much, Jeff. And I think that's actually a perfect way to wrap up today's event. There was also a comment and sort of a question from Ali in the chat about no one bringing up yet the effect on the profession and the value it provides, and of course with other healthcare providers. And so I think that will probably be Pharmacare and CPE version 3.0 with Joseph and Mike and Jeff and Zubin. So thank you to everyone who is still joining us online. Thank you to Jeff, Joseph, and Mike for such an engaging panel discussion. And there's so much more that could be said beyond the hour that we have today. So with that, I'll say thank you and stay warm, everyone. And we look forward to seeing you again at future CPE events. Take good care.